If you have 40 inches, okay, so that's 40 to table, all right? If the patient will fit lengthwise, which most adults do not, okay? Some of your shorter stature people may, but probably not even Jess or anyone else would fit on there. It'd be close. So if it's going to be close, why risk cutting? All right? So you want to turn the film diagonal. So before I get the patient, if I'm doing the Tib-fib, I go ahead and I get my cassette on the table, and then I open and get full film coverage. So from corner to corner, I'm not there. Okay? So I can raise my vertical. That's as far as that goes. So now I got to lower the table a little bit. So now I don't have to touch my collimator. I've got corner to corner coverage with my cone filter. So now I go get my patient and I bring them in. Who wants to be my patient? Huh?
Do you, at what point do you there's no change of technique for whatever inches you
Okay. That's approximately 44 inches to the table now. So I've increased my distance by 10%. So you could actually calculate it out using the new mass formula.
Oh, that's what I'm asking, do 2 squared.
Yeah. So you can figure that out. Because I'm right at about 45 inches. So I've increased my SID by 1/8. So yeah, you're going to have to increase your technique from what you normally would. So typically, your technique is somewhere between an ankle and a knee. Knees around mid-60s at 6.2 or 6 or somewhere. Okay? Tabletop. All right? So with this tabletop, so again, you're going to have to account for that. And again, with digital, it's not that critical, but when you go to Sacred Emerald Coast that crests you, that's film screen. So if you increase your SID by 4 or 5 inches, it won't matter.
It will matter.
Oh, heck yeah. Yeah, that's WYSIWYG.
What you see is what you
What you
get.
see is what you get, or what you shoot is what you get. There is no compensating. Okay? So I've already got everything. All right. And when doing lower extremities, if I'm doing the left one, I have the patient slide over to your right, to your left. Slide over some more. This way I get the leg about the center. This way this gives me more room to work. And plus also when I roll her up on her right side, now she's rolling toward the center of the table. So I'm going to have the patient do all the work. I'm lazy. Well, at least I think lazy. I'm not lazy. Okay? So I think like a lazy person. All right? So I'm going to be centering about mid. Okay? All right. So when I position, if they can lift their leg, if not, I lift their leg and I put the tip high up in the popliteal. Try to put it in the center of the leg. And that's about the center of your leg, right? Now, with that, I'm able to keep that anchored and then just wiggle the bottom of the cassette like this. Okay? So then I can just pull the cassette like this, and there's her apex patella. Here's her.
Pull my leg up so we can see. Pull my.
Pull your leg up.
You know
You're
what I
limber,
mean?
aren't you?
You always pulls your leg, don't worry.
You know what I mean?
Either with permission or without. Okay, so what we're going to try to do is get the joint, the knee joint and ankle joint. All right, where is the knee joint?
There. At the
What anatomical half-inch below the apex of the patella? Right. So knee joint is right about there. Here's the mid-malleolus. So these are not equidistant. So just gently slide the cassette down a little bit.
No, actually.
Right. Okay. So now it's approximate equidistant. So the ankle and the knee are on there. I've coned out. I don't have to cone. I have to leave it all the way. Because since I've said it, if I do grab it by mistake, I just open all the way. I don't have to worry about it. And then just cone it because you don't want to do that.
Okay, what about the 4 borders rule? Is that okay?
Well, you do have
Yes.
a
Yeah. Remember, anytime you have border to border or corner to corner, the computer sees that.
The corner to corner.
So This is one border, this is one border, and these two borders, okay? Now there tends to be a slight bow, right? So just rotate the leg until the epicondyles are parallel. And again, where's the thinnest part of the leg? Distal. Okay? So the rule of thumb when doing the extremities is distal lateral. LD, remember? Okay, so there is the AP Tib-fib.
And these are what you want parallel?
Parallel, yeah.
Okay.
Okay? And typically you have to rotate the leg in 3 to 5 degrees. Where have we heard those angles before? For the knee. Okay? Alright? I'll go ahead and show you the lateral. So I'll tell the patient, go ahead and roll up, and I put the new cassette under in the AP. Alright? Now, again, this is where you have to work with what's best for you. Alright? If the patient, and most females can get their knee lateral by not crossing the other leg over. Alright? If they're uncomfortable doing that, you can get a sponge and prop the leg up like this. Okay? But again, most patients, you don't want them laying up trying to look because that throws everything off. But I understand for y'all. Okay? So you can either hold your leg there. So again, you want to just pull the cassette diagonal, diagonal. And again, if you want, cheat, you know. Diagonal, diagonal. That's pretty good, except here's the joint, here's the joint.
So you push those.
So yeah, just a little bit. Okay? Turn that, and if I've got that, and if I need to move her, and then I can, she's on the cassette, and I can just move her a little. Alright? Now, from this position, is her knee lateral, under-rotated, or over-rotated?
Over.
In order to tell, it's easier to look from the side. Now, is her knee from over here, does she look lateral, under-rotated, or over-rotated? Under-rotated. Okay? So again, that's when you just have them rotate the leg there. See the difference? But now you're very close to having that cut off.
What made you see from the side that you thought?
Or stay where you were, there, right? You stand right, look. Roll back, right there, right? Now, look, does that knee look lateral? Look under-rotated, over-rotated? Okay, look at that. Look at that. And look at that.
Over-rotated.
Over-rotated, lateral, under-rotated.
Oh, that's pretty subtle.
Yeah.
So if they were over, under, how would you tell them to move their hip forward or back?
Yes. No, you rotate.
Verbally.
Okay, I just, as I rotate her hip, right, her knee goes. If she's under, typically with the leg back, they tend to be under-rotated, just like she was. You know, this is Miss Stewart's preference, and that's fine. My personal preference is I bring the leg up like this. And that tends to roll them into position more, but that's Frank's personal preference, and that's all it is Frank's personal preference.
I
Okay.
did that, I did a practice on Derek, and he couldn't do that.
That's fine.
So I just had him.
You know,
Which is typically the other way around. Most time, guys have a hard time doing it this way and getting lateral. Okay, but again, that's why you have to kind of assess your patient and then work within their limitations. There is no one way to do almost any exam, especially when you start talking lower extremities, trunk and torso. Okay? All right, so again, from this time, don't move. All right? In this, is she lateral, over, or under-rotated?
under.
Under-rotated.
And we're doing the Tib-fib, so that.
So the position is basically the same. The same basic position will be what you want to see for the Tib-fib lateral, the knee lateral, and the distal femur lateral.
Yeah, but if I don't get the, if I'm off on the Tib-fib, it's not, doesn't matter as much. If I'm shooting the knee and I can't see that.
It does. If you're not lateral, you're not lateral.
Yeah, you're using the knee to get to a lateral.
Yeah, you're
tib.
using your knee to tell whether you're lateral or not.
Okay.
Okay? Now, if you get someone, relax. If you get someone who's really tall, like I was gonna say, like Patrick. All right. I was thinking of Sean, but Sean's in the second years. And you need to sacrifice a joint. Which joint are you gonna sacrifice? if you cannot get both joints on a Tib-fib, which joint do you think you want to cut off and have to do it separately? Ankle. Because that's furthest away from, you can keep them shielded, but that's furthest away from sensitive tissue. Okay? Right? So if need be, you have to do two. Make sure you get the knee lateral and then do just a separate lateral ankle on a small film. All right? Okay? Go ahead and relax. So from here, we're going to go ahead and do the